question is the same for both of you.
Oh, good.
What you do for a living. Was there a pivotal moment where you decided to go into your healthcare profession? Because both of you are very dedicated to individual patients and not just turning and burning people out the door.
Mm-hmm. Pivotal moment.
Oh.
I worked as an exercise physiologist in a physical therapy practice that did cancer patients. And the moment I saw a woman like, I can do my hair again because we had released, or the physical therapist had released everything, I was like, I got to do that. I want to give people that joy. That's me.
Yeah, I started out real early as a kid going to a chiropractor. My grandfather was really the first one who got into it. And we got my mom into it. She had sinus trouble, was suffering from that off and on all the time. And so by getting adjusted, that all cleared up. So we started going as kids. Just seemed like a lot of fun, a lot of people getting healthy. And I just kind of took a love from it early age, probably like when I was like 12 years old. So been stuck with it ever since. Yep.
Cool.
Yeah. Cool. All right.
All right.
Thanks.
Well, today, so I'm Dr. Jonna Bigliani. Today we decided we were gonna talk together so that we can really show you how we're different and how we're the same. So we're gonna talk about scoliosis. That's an easy one. Everybody sort of understands it. And so scoliosis is only one example of how we can work together. I'm gonna hit this, so I'm gonna just move it. Okay. Of how we can work together and how we differ. So what is scoliosis? Scoliosis is any kind of spinal curvature. They can look like this. A little S, they could look like a C. There could also be a few rotations. And you could see someone standing perfectly straight and have no idea that they have a significant curvature simply because of how it corrects itself. Usually it's measured by angle. So if the angle is greater than 10 degrees, so if the angle here plus here is greater than 10 degrees or however it's measured in a radiograph, then that is termed scoliosis. And there's all kinds of different types. It can happen. That's your turn.
Oh, you want to start off where it can happen? Basically, what I talked about, I'm going to hand out this folder. This talks about the levels of degeneration. So with scoliosis, we obviously have, like Doc had mentioned, a lateral curve of the spine. And what we have found, the most important thing is to get it early. So to get your kids checked, to get your kids x-rayed one time in their life, there's that sweet spot before the spine matures and everything, and all of us will probably all feel that as we get older, things seem to lock into place. Same thing with the spine. A child's spine is still growing. They're still moving. So they can be these, I've actually seen with scoliosis, the biggest thing is the sacrum, which is the big bone but back here. Started out as 5 bones, then fuses together. And when that sacrum is out, that begins that phase of scoliosis. Another thing too, it's hereditary. So if any of you here know anyone or yourself has scoliosis, runs in the family. Very important again to get the kids checked because you can get that corrected. Until they reach about that 18, 19 years old, we can never fully correct it. There's a lot of improvement we can do to get them functioning better, but we can't really correct it when they're, unless you get them when they're very young.
So, took my point, but
preventing,
yes, I'm blue.
Oh, sorry.
All right.
I didn't read it off there.
So early, but you could also have late onset scoliosis that could be as a result of a hip issue or a leg length discrepancy. And so over time, the spine can tend to turn. And that is something that even though we might be getting older and the joints may not move in the same way, we can also make changes. So early identification and conservative management is basically the way to go.
Sorry about that.
That's okay.
So the other thing I'm going to pass out here is scans. So I mentioned thermal scans. The first is what a normal scan would look like, and the second is someone that is subluxated that needs to be adjusted, treated. That's what we do in our office in the very beginning when you're a new patient. We do your very first scan, but we also do it every time after your treatment so that we could see the adjustment before. Did it take place? Is it having an effect on that scan? So important with the scan because it shows the more degrees that it's off to the right or left, the more that your body is heading towards that disease process. Could be 25, 30 years down the road, but it's not functioning in the proper way. So one big thing that what I learned first in school was we call it a constructive survival value, which means the opposite would be deconstructive survival value. Yes. Like Steve said, like the predator. You'll probably pick that up as you see that. But those are very big things because constructive survival value means that are you every day growing into health or are you growing into a disease process? And that's one of the biggest things that I'm concerned about is when I look at someone, obviously when we want to get them out of pain, we want them to start functioning better, but we also want them to be on a path of healing so that as we get older, we're more, we can stay healthy and not have those problems develop. Yep.
So let's make sure we're on the same page.
Oh.
Right here. All right, so.
Baseline. You got it. Oh, good with the angle.
So the important part. So I'm gonna skip. I'm gonna go through with you. What we were trying to do here is the importance of collaborating physical therapy and chiropractic because it's a holistic, well-supported care.
Absolutely.
Good. Now we're gonna go on to looking at how do we assess.
Good point.
Scoliosis in a physical therapy environment. And so one of the things that we do is we look at a full postural and movement analysis. We look at how people are standing. We look at how they bend. One of the things that if we all might remember, some of us traumatically remember in front of the whole school, like, yeah, bend over and let's stand on the scale. Anyways, I don't do that anymore. But it's bending over. And so taking the time to look at every segment. And so having them turn, you might see that oh, that feels good. When somebody has scoliosis, you will see that as they bend, because of the rotation of the spine or the side bend or the curvature, and the ribs, right? So my fingers are the ribs. If the ribs are attached here, well, obviously one of them is going to stick out more. And that's the easy sign that you can see, oh, wow, that's really crooked. Even though when they're perfectly straight, they don't see anything. So, and the other thing is we measure. I'm not a big on goniometers is how you measure different angles. I just eyeball because I've been doing this for 18 years, so I got it. And the other thing is that functional movement. So we take the baseline measures of like, okay, how much do they bend, side bend? Can they stand? How does the pelvis move, right? And then we look at functional tests. How can they squat? Can they stand and do a little mini squat? And what happens to the rest of the body to compromise with a compromised spine? The biggest part is the quality of life. Oftentimes, kids, okay, yeah, they bend forward, then the nurse sends that little note, oh, you should get them checked. But the other part is kids start complaining because some of those curvatures might be so small. And then as they go through, they look at them in elementary school. That's when they sort of did it for my kids. Mm-hmm. But by the time they grow and they actually develop, they're now in middle school and even high school where they start to have the pain. Plus they have to sit longer in class, and so it's very uncomfortable. And so we look at the quality of their life. That's really where we're going to see. And one of the tests that I like to do, it's called the patient-specific functional scale. Each patient, and I do this for all patients, they take 4 activities that they want to do. Is it, a specific ballet move that they have to do this? Is it that they have to pick up their kids from the floor? Whatever it is, and give it a rating. And then it creates a it's qualitative, but we're quantifying their limitations to say then, oh, okay, as we progress, how is it getting better or not? And questionnaires. So some of the things then for the assessment is I take a look at, I touch the skin, I look at the joints and how much movement is within the joints, the soft tissue, the joints, and the muscle length. What happens here is with that curvature, one side gets longer and one side is, that long side is weak, that short side is tight. So muscle length is important. And that is how we assess. So now you tell us how you assess.
That's how we assess.
You were saying the imaging.
Yeah,
right?
the imaging. Yeah, I got a little ahead on that, but that's the first part, how we assess, and that also brings up some notes I had here. With really, we talk about when does the first subluxation begin? Does anyone have an idea of what traumatic process might happen when you're very early on in life? Birth, right? So when the doctor pulls the head out, a lot of times they're pulling and twisting, brand newborn. Do you think maybe those bones can start to shift out of place? So that's really where it starts. So many of you have never been checked in your whole lifetime that can go on there. So that's the first subluxation. The scan is the first assessment. The scan's always going to show that. The next thing we do is, if you are a candidate, after we see the scan, we're going to go with the x-rays I mentioned. We have digital x-rays, going to show us the posture where it's at in the beginning. And then we're going to look at functional. So how are those spinal bones moving? Are some of them stuck? Some of them subluxated? Some need to be worked on. And we can get about 5 or 6 key points in your spine that need to be worked on to start to fix the posture in the right way.
So now you can go right into treatment.
Okay,
now it's your
good.
turn. Now we're going to go to treatment, and you can go right into treatment.
So treatment is definitely specific for every case. Some of you are going to need a lot of treatment. Some people come in with pain in the neck and in the low back. Some people just one or the other. Some people, believe it or not, could have pain in the low back, but the main problem is from the neck. They'll say, oh, I've been worked on all the time with my low back. I've had this pop, crack, da-da-da. Nothing ever happened. I look at their neck, and the neck is really out. So that would make me focus, obviously, on the neck there. So the treatment is really tailored to each individual. But the outcome is the same. It's going to be more intense in the beginning, probably the same as Doc works with you. More intense in the beginning, more adjustments, because we have to get these bones back to their proper position. And then we start to taper it off because you begin to hold your adjustment. And as you hold your adjustment, it's less care. And that's when we start to go from a restorative phase to restoring the spine to more of a maintenance phase to keep you there and healthy. That's our treatment. Yeah.
Cool. So we definitely look as more of a whole person thing. And one of the evidence-based treatments that we've done, or that they've found, is the Scroth method. So I'm going to show you, because I don't feel like sitting on the ground, really. And for that, it uses specific curve-specific positional things, right? So if a person, they have to learn that if they're standing sort of, I'll take this off so you can see a little better, that if their curvature kind of puts them here, we have to teach them in front of the mirror how to use their muscles. Once we use, so we do hands-on, I was mentioning, soft tissue release, make sure their hips are fine. But once we've released that with manual therapy, now they have to learn, oh, I have to be here. And oftentimes people don't realize that they do this, and that's how they correct. So what we do with this is, and we add, it's a breathing technique, rotational breathing, that we do it in seated and in front of the mirror, that people are seated, find the neutral spine. So everybody sit in their chair and find Carrie was talking about this earlier, but you can feel your pelvis in the chair. So it's like, oh, okay, I feel my butt in the chair. And it's done at a height, so the legs would be kind of here. Okay, now we find the neutral. Now the hands go on the pelvis, on the hips. And from there, then, you can learn to more easily get your body sort of side to side. Not a side bend, but a translation.
You're wrong over there.
The hips don't lie.
The hips don't lie.
I am Colombian, by the way. So, translation. So, once they're in the mirror and they find that neutral, they see that, then we put the arms in different places, and there's breathing that happens at every level. Because as we breathe, we use the diaphragm to change the inside, and then the arms here, and you will see, and I just did this the other day with someone who had scoliosis. Before I even touched her, I said, try to fix yourself with this new breathing thing I just found, and it was amazing. She stood up, and it was so much straighter, simply because we work on the breathing techniques in different positions when they identify the neutral. It's not just about stretching one side and strengthening the other. It's about motor control and getting the person to understand and the brain to understand that you can put the two together and be in a new place. So that's more neuromuscular feedback with mirror, because me is talking because I'm saying it, and also visual and tactile, because I'm using my hands to put them in places. Then once they learn that neutral position, then we do different balance things, different proprioceptive things, and different functional movements while they're in that neutral position, that in their brain initially it's like, oh my God, this feels so crooked, but it's actually straight. And it's really functional integration. Once we correct that posture into their everyday things, like wearing their backpack or doing their sports or just sitting in class, it's their brain now recognizes what neutral is, even though their muscles are working differently on one side. But now they can maintain that spine, which is what you guys are doing in the clinic, is moving the spine. So we have a home exercise program and really a family integration as we look every time and see how they're doing. Because sometimes they don't even realize, most of us don't realize, what is that too? 10 minutes? We're doing it together. It's 20 minutes.
Yeah.
That's right.
It's 9 minutes. So we're on
that's
to
a
our
different
end.
one.
Okay.
Okay.
Well, is there
So,
anything you want to add in the 1 minute? Or?
No,
Okay.
that's it.
Good.
No, it's not, because now we have the additional time.
Okay.
That's right.
All
Don't
right.
be like cutting us off.
Well, I think this would tie. Wow. I think this ties in good with what Dr. just said.
It's good
And-
timing, actually, because now we get to
and
turn
what I
it
really
around.
want to drive home, this is my final thing, is that the reason that chiropractors work with the spine is because it protects the nervous system inside. 3 things to the nervous system: brain in the head sends more than 1 million electrical nerve messages down the spine, and then they go out to all these different nerves, or all these different nerves go out to every single organ, tissue, and cell in your body. So if any of these, like right in this area, T1, T2, these nerves go to the heart. If I were to go in there and cut that, what do you think would happen to the heart? You die. So this is the most important thing. If you can understand that, what do you think would happen if a bone is subluxated and is putting pressure on that nerve? How great is that nerve impulse going to that heart? Would that person down the road, you say, have some heart trouble? Yeah, that's my big point.
Cool.
Leave it.
I wanted to, hey, how's it going? I wanted to talk about outcomes. So our aim in physical therapy is to prevent the curvature progression, which is sort of similar goals, right? But the way that we do it and that way that we look is to make sure that their pain is coming down, that they have better function, and that it looks better, because for teens, oh my God, their look is like totally must be number one.
That is true.
The other thing is the psychological benefit of helping them take ownership and really control of their body, because it's empowerment, self-image, and activity participation. With less pain, they can sort of do more stuff. And inclusion, they look like everyone else. You know, the last thing they want is to look any different. So very similar goals. And,
I agree. Yeah, I think hopefully we wanted to kind of put the thing where you see we both have the same goals, but we're kind of looking at it from different ways. More for chiropractors, more inside out, allowing the body to heal and to do its thing over time. But there's always going to be complaints. There's always going to be issues and things that connective tissue is a big thing that we mentioned too. Things that you need to work on to get you moving better and feeling better in a shorter time.
So why is multidisciplinary care, why does it work? Well, physical therapy addresses muscle, movement optimization, and chiropractic care supports the alignment, the mobility, and the synergy in those outcomes.
Yes.
So the important part is the unified family and patient education plan.
Exactly.
So now,
I really went off script.
regular, I don't know where you are. Regular joint, because you're going to talk about why working together matters. So you're black. Yeah,
the biggest thing that I see when in the office, we are allowing the body to heal itself. So it does take time. And a lot of times I'll look at that scan, wherever that ended up now, and it looks good. It means that what I did the visit before has done its thing. The body is healing. But what's going on? Oh, I'm still got all this pain. I can't get through the day. I can't sleep. I can't do those kind of things. This is where I think it's a great compliment.
That was 20 minutes? 18 minutes?
18.
And that was 18 minutes?
So,
Awesome. That was perfect. So that's exactly what we were trying to show you.
I still thought we had 20 minutes, but yeah.
I know. And I know that you had a raised hand, so we can do a one-to-one if you have any questions.
Yes.
So same but different. We work together, and anybody can go whichever way they feel comfortable with.
Awesome. Thank you, guys.